So as you all already know, atrial fibrillation is associated with quite a lot of morbidity beyond the symptoms that we are trying to treat with our ablations. This one is one of the most feared ones, the fact that patients with atrial fibrillation have much higher incidence of stroke, of major stroke, and that's why those patients also have to receive anticoagulation, most of them for the whole of their lives. These patients not only have a higher incidence of stroke, independent from other cardiovascular disease, but they also have a higher mortality. And what has already been seen, getting nearer to this microembolism, is that these patients, independently from ablations and other kinds of interventions that we can make, have a higher prevalence of silent microembolism in routine MRIs that were performed because of something else. That also gives us the idea that those patients during their life in atrial fibrillation have this small embolic event. What has also been described is that patients with atrial fibrillation here in a very big group of patients presented a higher incidence of dementia from all causes, which gives a strength to this relationship between microembolic events and cognitive impairment in those patients. This is a slightly smaller study, but I wanted to present it too, because in this study, they even made a differentiation between paroxysmal atrial fibrillation and patients who had a chronic atrial fibrillation, persistent atrial fibrillation, and so that these patients with longer episodes of atrial fibrillation did even have a bigger cognitive distress compared to the ones that had paroxysmal atrial fibrillation, which could gives us the idea that the amount of time, the AFib burden, plays a role in the incidence of this microembolism and in the cognitive decline. Well, ablation of atrial fibrillation, that's why we are here. It's a technique, a very good technique that has been evolving a lot in the last 20 years with the goal of rhythm control in patients with atrial fibrillation. At the beginning, we were trying to have complete rhythm control to completely eradicate the atrial fibrillation. Now, we have also seen that there are other things that can be achieved beyond this complete elimination of atrial fibrillation, which is a decrease in the AFib burden, and maybe just with that we could also decrease the amount of microembolism and the incidence of this dementia and this cognitive decline. Of course, on the other side, the ablation itself has its risks, and we all know from the very beginning that there are strokes associated with the ablation itself, with an incidence that is around 1%. Quite constant among the data that are published. On the other side, we have also very nice data. For example, this data on a very big group of patients that were just prospectively followed after an atrial fibrillation ablation in many centers in the US, and where they saw that even patients with a high CHED score, where one would expect that the patients had a lot of stroke events not being on anticoagulation, some of these patients were left off anticoagulation. Of course, it was not a prospective study, it was just something observational, but those patients presented extremely low rates of embolic events after a catheter ablation of atrial fibrillation, so that our stratification that was valid before the catheter ablation might not be useful anymore after the ablation because we have modified some things. So there is still something good. And the same group that talked about the higher incidence of dementia, of all-cause dementias in patients with atrial fibrillation, has also described that patients after an ablation of atrial fibrillation have incidences of dementia that get back to normal. So that even if we are getting success rates of 60–70% that are quite homogeneous, no matter what technique we're using, it seems that just by decreasing the AFib burden, we might be doing something good in the direction of decreasing the incidence of dementia in these patients, which would be very nice and very positive. The only dark cloud in this story was the appearance and the recognition of these silent microembolic events after ablations of atrial fibrillation. The whole thing started with this very small study from 2006. This German group made MRIs in 20 of their patients after an ablation of atrial fibrillation. In some of them, there was a previous study before the ablation. Some that were the last ones. The first one were just the study after the ablation. And they found 2 patients that was a 10% incidence with fresh lesions, with new lesions in the MRI after the ablation. One of these patients, when they made an accurate examination, presented even a discrete hyperreplexia in the contralateral side from where the lesion was seen. So that suggested that it was really an ischemic event that would have been unrecognized if there had not been a neurologist that had gone there and just took a look at it. After this very small study, 2006, 4 years later, came the big study with 232 patients from the group from Gaeta, where they had 1 patient that had a symptomatic stroke, incidence from 0.4%, quite in accordance to other data that have been published, but an incidence of 14% of silent microembolism. So concern started about thinking what is exactly the meaning of this microembolism, where do they come from, how can we avoid them? In this second work from Gaeta, he tried in these 232 patients to look for factors that could predict the appearance of this microembolism, and found at the end that the anticoagulation and the cardioversion during the procedure could be predictors of the appearance of this microembolism. After these 2 works, in the last 3 years, quite a lot of papers on this topic have been published with different techniques, with different amount of patients, and I'm going to try to give a summary of them and to also clarify a little bit why are there such different incidences, because when you start reading it becomes quite quickly a little bit unclear what is playing a role on that. So I'm going to start by the studies that involved just patients ablated with conventional irrigated tip radiofrequency catheters. And here you see, if you take them all together, there are a little bit over 700 patients, with 4 patients that presented clinically neurological symptoms, including this one that had just this very slight abnormality in the neurological examination. The other 3 ones had a clear stroke. And that comes to an incidence of clinical stroke of 0.5%, so this is more or less what we would expect. And the incidence of this microembolism in the MRI after the procedure are varying. Actually, just for irrigated tip catheter, the variation is not so big. It varies from 6.8. This one is a figure that is quite different from the other ones, because all the other ones stay maximally at this 15%. There are, of course, other studies that have been made with other kinds of catheters. This is a table just summarizing the one-shot catheters. Of course, the one that had raised the most concern were the first figures that were published with the PVAC catheter that were quite high, with incidences of 40% of microembolism, and that had been improved just by modifying some technical aspects on the ablation using a PVAC catheter that Dr. Haynes is going to explain us, I think, in quite a big detail, so I'm not going to go a lot in that direction. As another one-shot catheter, we have the cryoballoon. Here the figures are quite good, I would say, excepting for this 50%. I will comment on that afterwards. But the other ones are all below 10%. And there is just one figure using the mesh catheter, just with 20 patients is quite low, 26% quite high. Why are those differences? Even using the same catheter? Well, of course, as I already mentioned, a lot of things were done differently, not just the catheter that was chosen for performing the AF ablation. Just starting with conventional irrigated tip radiofrequency, well, it is not the same whether you do segmental PVI, just ablating for the entry sites around the vein, or whether you're targeting a really wide circumferential PVI, or whether they are trying to do lines, even to do cafes. There were really works where patients received a very wide ablation and other ones where they received a very small ablation. There is maybe a very small trend that shows that the smaller ablations could have a little bit less of embolic events, but there is absolutely no clear trend. This group from Japan were the only one that found that cafe ablation could be related with the appearance of deep microembolism. But there is really no clear trend where we could say if you ablate less, then you're going to have less microembolism. And of course, something that plays a very important role, and that my colleague already discussed a little bit, is how you define the lesions. Because most of these studies were done with MRIs, all of them were done with MRIs using diffusion-weighted sequences to detect these embolic events. Diffusion-weighted sequences detect cellular edema. It's an extremely sensitive technique for detecting embolic events, and the lesions are visible after minutes. It's extremely fast. More or less half of these studies combined also flare sequences. Flare sequences are a little bit less sensitive because they are a little bit more specific for cellular lesion. And lesions are seen a little bit later, but at last 6 hours after the intervention. So that should have been a problem for the studies where the MRI was done 24 hours after the PVI. Now let's take a look at the published incidences of these microembolic events according to this definition of the lesion. And here you see, for example, that this very big, this high incidence of 21.4% is in a study where they just took a look at the diffusion-weighted images and there were no flare sequences done. So that maybe here we are seeing some temporary edema that is not going to end into a real cellular lesions. And then we are seeing more of what we would see by also matching with flare sequences images. Although this is not completely consistent, these studies here also used only diffusion-weighted and ended up with figures that were a little bit lower. We have in another table later another possible explanation. You really have to take a look at everything. The studies with one-shot catheters were done, most of them with a combination of diffusion-weighted and flare sequences. The only one with PVAC that was done just with diffusion-weighted was the one by the group from Denneke, and ended up also with quite a high figure. And this one that presented, I already commented before on this one, on this 50%, also used only diffusion-weighted, and it was the only study among everything that has been published to date that used a 3 Tesla machine. All the other ones were done with a 1.5 Tesla machine, so that might have played a role too. That's why these studies are so difficult to compare to each other. There is only one study that published both incidences, the one that they have just performing diffusion-weighted sequences, in this study from this German group with PVAC, and they had an incidence of 27% of silent embolic events with diffusion-weighted after taking only the patients that have an image also in the flare sequences. The incidence of the events dropped from 27 to 8.1%. It's just a single study, it's not a lot of patients, it's 37 patients, but it also confirms this idea that only performing diffusion-weighted is maybe oversizing the effect. That is, of course, a cause of care, but what we really care about are real cellular lesions. If the cellular has a little bit of edema and recovers, then it shouldn't be so problematic. And what about the anticoagulation? That has also been a matter of concern. There have been not a lot of studies that have been performed under running anticoagulation. Most of them were done with a bridge into heparin and with different cutoffs of ACT. I have on purpose put the studies on a chronological order so that you see that the anticoagulation pattern over time has become more and more aggressive. And, well, this is my personal opinion, but maybe we are overdoing in the other side. Because actually, by going from, bridging from heparin and ACT scores over 250, the first published incidences were 10%, and the last one, with quite aggressive anticoagulation and ACTs over 300, are talking about an incidence of 12.2%, and both of them are defined by diffusion weighted. So anticoagulation is important, might play a role, but is not everything. In the case of one-shot balloons that are using also very, very big sheath, anticoagulation has also become a concern, especially in the case of the PVAC, and that's where I was saying that maybe we're overdoing it, because this last study performed with a PVAC that ended up with an extremely good incidence of these silent embolic events of only 1.7%, that was one patient actually in the whole cohort, was done under a very aggressive anticoagulation, because the goal of the ACT was over 350, but the mean ACT was almost 450, which is extremely anticoagulated. And of course, the authors came to this very low figure. And now it's very difficult to figure out, because apart from that, they also did many other things. And it's very difficult to take apart what is contributing to what. But I would say the rest of the data is not really suggesting that a very, very aggressive anticoagulation is able to drop the microembolic event ratio so importantly. Many of the studies has, of course, tried to look for predictive factors of these embolic lesions. And actually, they failed to find a common factor, maybe excepting for the PVAC when it was compared with the two other catheters and with the initial technique that was 2 years ago. These were these two studies comparing the three techniques, and both of them just found the PVAC as a predictive factor. But apart from that, there appears to be a certain influence on the patient itself. So there were two studies that found the age of patients as a significant contributing factor, and a lot of them found a trend to presence of spontaneous echo contrast in echocardiography, or the technique that you use. I also mentioned about that, ablation of CAFEs, coronary artery disease, the volume of the left ventricle, septal hypertrophy. The further study that had been done afterwards were not able to reproduce the first results by the group of GAITA, and no further study has been able to find the anticoagulation during the procedure or the cardioversion as a predictor for the appearance of this microembolic event, so that it seems to have been just a statistic coincidence of this group. I think also the problem is that this has been done with different catheters, with different strategies, which I had already said. And in the case of the PVAC, in these studies, the PVAC at that stage, with the technique done in that way, was really causing a lot more of embolic events, and then it statistically completely eliminated everything else that you could have seen. And just a couple of words, because my colleague already spoke about the transcranial Doppler, because I think it's very nice. We have seen this all varying incidences, and many authors have tried to do statistical analysis and trying to look for possible factors that are increasing the risk for having these microembolic events. But I think the important part of it is understanding where they are coming from. Because if we are able to understand what we are doing wrong, then we are going to be able to understand how to do it right. And there are two studies using transcranial Dopplers that give a couple of interesting insights. This is one with 200 patients where they performed transcranial Doppler, and I just wanted to to talk about these figures here. These here were different phases of ablation, where they were registering whether they were able to register embolic events with transcranial Doppler. Here, the phase 1 was just the puncture of the groin. Nothing was in the left atrium. And here, the phase 5 was after removing all sheath from the patient. And as expected, and we are very happy about it, there were absolutely no embolic events detected on those two phases. There were 5 minutes, 10 minutes of it. It was not a very long register. And everything was happening in these two phases. Phase 2 was after the transeptal puncture, flushing of the sheath, introduction of catheters, making the anatomy. No ablation was happening in phase 2, but there were already things happening on the embolic side. And of course, most of the embolic events were happening during phase 3, that was the ablation. Also to be said that this study was done with an 8 millimeter non-irrigated catheter, and in that case they also controlled for the formation of microbubbles in intracardiac echo, and they could find a very high correlation between these embolic events in transcranial Doppler and the appearance of microbubbles in intracardiac echo that were suggesting an overheating of the tissue. So that gives us a little bit more of insights. What is happening? Why are we finding that? This is another study introducing the cryoballoon and comparing irrigated with non-irrigated radiofrequency. I just wanted to point a couple of things of this table. The one thing, they also measured here the occurrence of these embolic events during the placement of the catheter and during ablation, and also found that had happened too during the placement, especially with the cryoballoon, big sheath, placement of a very big device. This is really something that has to be taken with a lot of care. And as expected, a lot less of embolic events using irrigated RF compared to non-irrigated RF. Just one word to electrical cardioversion. I think that was done because of this suggestion that electrical cardioversion could be related with embolic events after an ablation or AF. There is one Spanish study of 62 patients that underwent an electrical cardioversion and an MRI 24 hours after the electrical cardioversion, where there were absolutely no silent embolic events. Absolutely none. Just to conclude, silent embolic events are a complication. I think it's not just an event, they are really a complication of our ablation procedures, no matter with what we are doing them. It's something that annoys us to hear it, but it's something important to know about. Their clinical significance is, of course, unclear because it's very difficult to measure that. Cognitive decline is something that is going to have in 10 years, but we are ablating young people that have a life expectancy that is over these 10 years, so we really have to care about it. Its incidence, which is also interesting to see, doesn't really seem to be correlated with clinical strokes, because even in all this PVAC series with incidences of 40%, there was not a single clinical stroke. It doesn't seem to be really correlated, doesn't seem to be a good surrogate of it. Its causes are multifactorial. The characteristics of the patient himself play a role, but the characteristics of the procedure, I think, are play the main role in it. And it depends then on the kind of catheter that you're using. Whether you're using radiofrequency, then it should be irrigating, trying to avoid sharing, be careful with big sheaths, be careful with flushing sheaths, and of course, on the PVAC, a couple of more of technological aspects. And just as a very last remark, just to say, of course, we know nowadays we are doing AFib ablation because of symptomatic indication, but actually we would all want to help these patients in what is really giving them problems concerning AF, which are not only symptoms, but this very high morbidity, this high mortality, this higher incidence of strokes, and the higher incidence of cognitive decline. And we have to work to eliminate that incidence of microembolic events so that we are really able to say we are going to do AF ablation because we are helping the prognostic of the patients in general. Of course, waiting for that, I just had to say we are all waiting for the big studies that are going to help us take this decision and tell to our patients that we are also helping them on that side, and not just with their symptoms and their palpitations. Thank you very much.